My name is Uri Kogan, and welcome to the webinar today. We're going to be talking about making the business case for infection prevention. So today's webinar is the fourth in our series, and if you missed any of the prior webinars, make sure you leave a comment in the chat, and we'll be happy to email you a link to the recordings. So as I already said, my name is Uri Kogan, and I lead product marketing here at R0. And today I'll show you how adopting UVC as a layer in your disinfection and janitorial practices can pay off for the safety of the spaces you manage and occupy and for your bottom line. In fact, I'm going to show you that in many cases, the cost of implementing UVC can be lower than the savings, even in the first year. So you can get started without any capital funding or budget cycles and still come out ahead. I'll walk through 3 examples in a hospital, a school district, and a senior living facility to show you. But first, let me share just a little bit about the efficacy and sustainability of UVC. We've worked with hundreds of customers, but here are just a few examples. At the Mayo Clinic, they tested our upper room germicidal UV device called Beam and our continuous disinfection far UV device called Vive. I'll show you those a little bit later. In 2 lobbies, a bathroom and a cafeteria, and they saw between a 96% and a 99.8% reduction in B. subtilis spores, which are a common way to test the effectiveness of disinfection because they're really hard to kill. In one of the 5 largest U.S. school districts, R0 installed air disinfection systems in 7 schools and measured the presence of COVID in the wastewater compared to schools without the air disinfection. And what we saw was that schools where R0 technology was reducing the microbial load in the air reported over 50% fewer samples containing SARS-CoV-2 compared to the non-intervention schools. And at Trilogy Health Services, which operates over 120 skilled nursing, assisted living, memory care, and independent living campuses from Kentucky to Michigan, and has over 11,000 residents and 14,000 staff, an independent study was run at one facility that showed, or rather the goal was to evaluate the real-world effectiveness of UVC devices. And what it showed was a 99% or greater reduction in viable surface bacteria, a 93% reduction in airborne microbes, and a 3-log or 99.9% reduction in the B. subtilis spores. So suffice it to say, we've seen this play out with incredible success across all kinds of facilities like the ones that we're focused on today. Now, UVC is generally, if you're thinking about UVC, you're going to evaluate it on 2 fronts, effectiveness and sustainability. So let me explain a little bit about how it helps on both fronts. On the efficacy side, UVC allows you to rapidly disinfect spaces. It works really quickly on both air and surfaces, depending on the device, to achieve, as I showed you, oftentimes 99 or higher % of efficacy in just a handful of minutes. Secondly, it's autonomous. It runs on its own, by and large, and removes the dependence on manual human action and the dependence on people actually doing what they say they're going to do or what the protocol says that they need to do. Third, it's continuous. Those UVC formats that operate in the human-safe wavelength of far UV or that operate above people's heads can essentially disinfect air and surfaces in real time throughout the day, right when people are in the space, and of course when people would prefer to be in a space that has disinfected air and surfaces. So it's very efficacious. Let's talk about sustainability. When you use UVC disinfection, you don't have any chemicals. You don't have any of the associated negative externalities of chemicals on the environment, having to move them around, having to use them, having to breathe them in, or any of the other negative aspects of using chemicals. Secondly, it's much more energy efficient than using your heating, ventilation, and air conditioning system to pump fresh air into a room. You can get the same level of microbial reduction with 95% less energy than HVAC. That's pretty dramatic. And we all know that running our own air conditioners and heating systems at home is very expensive. It's similarly so, or even more so, in a commercial setting, given those kinds of facilities. Lastly, it's much less wasteful. Manual disinfection generates wipes. HEPA filtrations generates filters that have to be changed every 3 months. None of that waste stream is present when you're talking about UVC-C. The benefits of the move to UVC are clear. You get much greater efficiency, efficacy, better sustainability, and as you'll see today, a measurable and very significant ROI. So with that, let's turn our focus first to hospitals. It's been proven for decades that a layered approach to disinfection is the key to making hospitals safer and to reducing hospital-acquired infections. A 2020 meta-analysis of many different studies, several hundred on the topic, found 6 predominant methods. I want to focus on the first 2, hand hygiene and maintaining a safe, clean, and hygienic hospital environment. Regarding hand hygiene, the study mentioned that, quote, data-driven hand hygiene policy requires strict and routine monitoring and recording of compliance, with the data gathered being analyzed to identify and prioritize areas for development and enhancement. Now, studies have shown that good hand hygiene can reduce hospital-acquired infections by 45%. That is a really, really dramatic improvement, of course. Given that there are so many studies showing the importance of hand hygiene, why hasn't this relatively low-tech solution been more effectively put into practice? Well, it turns out that establishing protocols is not enough at all. One challenge with any disinfection system that depends on a very busy staff to decide it depends on a very busy staff to decide from 1 minute to the next, am I going to actually follow protocol as I enter this room, as I exit that room after procedure X or Y or Z? And the unfortunate reality, which is also highlighted by many studies, is that rushed staff often choose to skip steps. And one of the things that they often skip is hand washing. And to date, hospital managers haven't had a good way to do what the study I mentioned on the previous page was all about: monitoring compliance to the protocol, identifying where the gaps are, and creating training and building a culture to drive the change continuously and across the board. But now it is a solvable problem. You can use sensors, such as ones that R0 creates, that can count people at specific points in time and specific places, like is somebody at the sink after they enter a room? Are they at the sink before they leave? Is somebody using the dispenser of sanitizer on a regular basis? And that can help you over the course of time and over the course of the entire facility understand exactly what is going well and what is not, where hand hygiene practices might be falling short. And then software can bring visibility and data and insight on all of that to managers, to staff, to patients, so that you know what is actually happening and can do something about it. So let's now turn from hand hygiene to the value of maintaining a safe, clean, and hygienic hospital environment. If a layered approach for air and surface disinfection can lower the presence of pathogens in the air and surfaces that cause hospital-acquired infections, and as a result contribute to a hospital environment where those HAIs are reduced by 30%, what kind of financial benefit could a hospital reasonably expect from that? Well, let's start in the operating room. On average, surgical site infections occur in 2 to 4% of patients undergoing inpatient surgery. And in the average hospital in the US, there are 6 operating rooms and about 400 procedures per room per year. And so if you take that 3% mid-range of the number of surgical site infections, you would expect about 72 hospital-acquired infections from the OR every year in every hospital. Now, it goes without saying that the biggest impact of these infections is on patients themselves, of course. About 3% of patients that acquire a surgical site infection end up passing away. But today we're talking about financial metrics, so I want to focus purely on the enormous financial returns to hospitals that can reduce the rate of hospital-acquired infections. So let's talk about the direct cost first. The direct cost of treating surgical site infections was estimated at over $28,000 each by the Federal Agency of Healthcare Research and Quality in a study that was done 6 years ago in 2017. The data in that study is even older, and so the figure of 28,000 is almost certainly a lot higher today. But let's just make that assumption of $28,000. If layered disinfection can lower the pathogen load on surfaces and in the air such that 30% of those surgical site infections are avoided, an average hospital is going to avoid about 22 per year. And that means that the direct cost that they cannot reimburse, that they could avoid with a layered disinfection approach, is over $600,000 a year. That's pretty compelling, but it's only the beginning. There are many other benefits that $600,000 doesn't include. If a hospital can reduce HAIs in their wards by a similar 30%, a 500-bed hospital could save another $2.5 million. Now, the $28,000 to treat a surgical site infection only factors in direct costs. It ignores the opportunity cost of taking up a bed that would otherwise be available for someone else for a paying patient. And the average hospital bed generates over $3,600 in revenue every day. The typical surgical site infection and other HAIs tend to add over 8 days to the length of a hospital stay. And so when you factor in that about 1 out of every 200 discharges ends up getting readmitted with a surgical site infection or another HAI, a 500-bed hospital is losing out on several $1 million of revenue just from that indirect cost of not making their beds available for paying patients. Lastly, let's talk about the staff. An environment that has lower pathogen loads can impact staff. If only 10% of staff sick time is from catching infections at work, reducing that number by a similar 30% could represent roughly another $2 million more in savings based on the average hourly wages of healthcare workers in the US. So suffice it to say that there is an incredibly strong financial return for a hospital that can maintain a safe, clean, and hygienic hospital environment. And better disinfection technology is available at what's almost a nominal cost in a healthcare setting. So with that, let's turn our focus to look at the business case for UVC in a school setting. Now, school districts around the country and the world became dramatically more attuned to the importance of indoor air quality and infectious disease during the pandemic. Even as that pandemic has receded, in many people's day-to-day consciousness, one small silver lining is how much more aware we are to the possibility that annual viruses like cold and flu, which were much slower when we were socially distancing, they don't have to be just a yearly fact of life. And when viral loads are lower, we know that schools work better for their students and their staff. Absences go down, improving student outcomes and school funding. And teachers are less likely to get sick, which keeps them in the classroom and reduces the disruption for students and reduces the school budgets that need to pay for substitute teachers. Now, as compelling as all of those benefits are, I'm going to set them completely to the side. It turns out that for a typical school, protecting the highest risk spaces can pay for itself within the first year purely out of the operational savings from reducing the burden on maintenance staff and the need for disinfecting chemicals. Let's take a closer look at that. First of all, what is a typical school? A typical school contains a variety of different spaces that present different risks. R0 has the fortune of working with hundreds of different schools, and based on that experience, here's what a typical 900-person high school might look like. Our model school has 14 large classrooms, 26 medium classrooms, 4 small, a large and a small cafeteria, a locker room, a teacher lounge, gym, and auditorium. All of those are considered high-risk spaces. Now, what does that even mean? Well, different spaces have different risk. Classroom and auditorium and teacher's lounge tend to be high-density spaces. And activities in a space like coughing, singing, shouting, breathing heavily in a gym, all of those increase the risk that one sick person transmits an airborne illness to others. And those kinds of activities are common in a cafeteria, a locker room, a gym, as I mentioned. Then there are other spaces like bathrooms or the lobby or food prep that actually tend to have less crowding, or people occupy them for shorter periods of time, that tend to be lower risk. Now, it's important to note that as I'm speaking about these risks, that's a fairly general statement, right? That's kind of a typical what we see. But these vary from school to school, depending on the building, depending on existing ventilation, depending on the climate, the population of students and staff, whether people are masking or not, and lots of other factors. So while those estimates are a good starting point for evaluating the risk of a building, when we work with customers, we actually measure their specific environment with AI risk-driven models and sensors to provide much more precise targeting based on occupancy, CO2 levels, and other measures like the ones I mentioned. But let's just stick with this example for now for the sake of today's conversation. So in order to protect the high-risk spaces that we identified, we would recommend a combination of our Beam and Vive installed products depending on the room. So let me just briefly show you what those are so you understand what they do and how they help. So the R0 Beam is an upper room ultraviolet germicidal irradiation system that uses LED UVC light across the upper part of a room at 260 to 270 nanometers to stop microorganisms in the air from reproducing, which neutralizes the risk that they pose. The R0 Beam is actually the first ever LED system for UV disinfection. Now, Beam works in the room when people are in it. When somebody's speaking, coughing, sneezing, breathing, the air that comes out of their mouth and nose is hotter than the surrounding air, which causes it to rise. And Beam directs a beam of UV light across the top layer of the room, disinfecting that air on contact. And the air is recirculated into the occupied space lower down through natural convection. And that provides occupants with a constant supply of clean air that's equivalent to changing all the air in the room every 6 minutes or 10 air changes per hour in a 1,000 square foot room. And then as you can see in the picture, there's a baffle on the bottom that directs the light away from room occupants. And that ensures that the UV level stays below established limits by OSHA for anybody who's actually in the room. The Beam also has 2 motion sensors that are constantly monitoring that disinfection zone. So if, for example, somebody were to stand on a desk or a ladder, or somebody super tall throws their hand up, the motion sensor is going to immediately turn off those lamps. So there's no risk. Now, Beam, this is kind of would look in a classroom, so you get a sense of how big it is and where it might sit on the wall. And now let's talk about Vive. So you can see Vive mounted to the ceiling of this bathroom. It looks a little bit like a light fixture. And in fact, it is a light fixture. It's just emitting far UV light. And it's emitting far UV light, which is 222 nanometers, which is a part of the UVC spectrum that is safe for humans. And it emits it continuously when people are in the space and after, to autonomously disinfect the air and the surfaces in rooms up to 200 square feet. It weighs less than 5 pounds. It easily mounts to the ceiling. And this far UV light is safe for humans. So it's really good for spaces like a bathroom where surfaces need consistent disinfection. So back to our typical school. Overall, the high-risk spaces in the school add up to about 64,000 square feet. And if we want to disinfect them, we would recommend a program like this. Again, this is sort of an estimate. We would adjust this based on real-world calculations if we were working with an actual school. But collectively, this works out to 53 beams and 2 Vives to produce much higher air changes per hour than was possible before, and generally in line or above the latest guidance from ASHRAE, which recommends 8 changes per hour or more, the CDC, which recommends 5 or more, and the Lancet, which says that 6 or more is best. In last week's webinar, Ben Boyer from R0 covered a lot of that in detail. So if you're interested in guidance on what is recommended by these standard bodies, I encourage you to check that out. Now, Beams and Vives are currently available for $9.99 each the first year, which works out to just under $55,000 for the 55 units that are spec'd in this example. And in the second year and subsequent years, the recurring costs are much, much lower than that. So if we're going to implement UVC for this example model school for the high-risk spaces, that implementation is going to cost about $55,000. Now, what are the savings that go against that? Well, the continuous disinfection of these spaces can significantly reduce the burden on janitorial staff who are wiping down surfaces, changing air filters and HEPA filters, and spending and using chemicals and filters themselves. So we've estimated that this can work out to a savings of about 90 cents per square foot every year, which works out to about $57,000 per year for the high-risk spaces. So that means that only factoring in this savings and ignoring all of the other benefits that we talked about, switching to UVC disinfection can pay for itself. And as I mentioned earlier, if you have cleaner air and surfaces in a school, the school will benefit from that in other ways. A healthier school is more likely to have healthier kids and staff that stay in school more days, increase the funding to the school, and lower substitute staff costs and disruptions. Now, there's one more really big area of savings for a school that implements this. And that is in particularly true for schools that are running their HVAC system more than they might have otherwise in order to increase air changes and to reduce infectious air with ventilation. Moving air and heating or cooling outside air is very expensive. Cleaning the air in place is much, much cheaper. A beam, for example, uses about as much energy as a laptop. And of course, cranking up the heating and cooling also generates a lot of greenhouse gases. UV disinfection to get the equivalent air changes per hour can reduce the associated emissions by over 90%. So net, investing in UVC to address high-risk spaces in schools is a total no-brainer. And as schools factor in the additional savings from higher funding and lower energy costs, it's also possible to invest in medium and lower-risk spaces with a first-year return. Now, we have a handy calculator on our website at r0.com/education, where you can create an estimate for your own school or schools. And of course, we'd be happy to discuss that with you and get into much more detail about precisely what you might need and what you might be able to do in your environment. So with that, let's talk about senior care. This is our third example and our last example. Our approach with senior care is actually very similar to a school in terms of how I'll walk through this. Of course, a nursing home is serving a very different kind of population and a different function, caring for parents and grandparents who may be frail or immunocompromised. And so clearly keeping a nursing home disinfected is absolutely critical and a high priority for administrators and regulators. The good news is that simply by reducing the labor and chemical costs of manual disinfection, a senior care facility can more than cover the costs of protecting all of its spaces. So let's work through a similar example here. First of all, a typical senior care facility has a variety of different spaces that have different risks. We've worked with hundreds of senior care facilities, and based on that experience, here's what a typical 100-resident facility profile might look like. It has some dining areas, activity rooms, physical therapy, and fitness rooms that tend to be higher risk based on how people use them. Kitchens, nursing stations, etc., that are a little bit lower. And then the private spaces tend to be lower risk because they are lower occupancy. And as I was just saying, different spaces have different risks. It generally correlates with how many people are congregating in the space and how people are using the space, whether they're breathing a lot more or more excitable as opposed to not. Now, again, as these risks are typical, they're going to actually vary from one facility to the next, depending on the building, depending on the ventilation, the climate, the population, etc. So we always, while we kind of give these general guidelines, we always only start with those when we're actually talking to a specific facility. We look at a lot more detail. We measure what's going on in that facility to provide much, much more precise estimates and targeting as to where to apply disinfection. But sticking with this example for now, in order to protect these high-risk spaces, we'd recommend a combination of beam and vive, depending on the room. Overall, the high-risk spaces in this environment add up to about 7,800 square feet, and to protect them, we would recommend a program of 12 beams and 8 vives that would produce much higher equivalent air changes per hour than was possible before, and again, generally in line with or above the guidance from ASHRAE, the CDC, and Lancet that Ben Boyer talked about on last week's webinar. And as I've said, beams and vives are available for $999 each for the first year, which works out to just shy of $20,000 for the 20 units that are spec'd above. And the recurring costs from the second year are going to be a lot lower. Meanwhile, the continuous disinfection of these spaces can significantly reduce the burden on janitorial staff to wipe down surfaces, change air filters, and reduce the cost of the chemicals in the filters that they're using. We've estimated that in a senior care facility, this can work out to a savings of about 10% of those costs, which work out to about 65% per square foot per year. That means that for the high-risk spaces alone, the savings are around $50,000 per year against the investment of about $20,000. That's an over 200% return on investment in just the first year. And that return on investment only gets higher in subsequent years when the costs go down. The math works similarly for medium and low risk spaces. I won't go through it in detail, but covering the whole nursing home with UVC disinfection can still generate an ROI that approaches 200% within the first year. So all in all, incorporating UVC disinfection is an absolute slam dunk investment, as are additional cost savings by using sensors to improve hand hygiene protocol compliance. Finally, I noted above that using UVC disinfection like our Beam and Vive products delivers higher equivalent air changes per hour that meet or exceed the latest guidance. The unfortunate reality is that many older facilities run their HVAC systems hard just to meet the prior lower standards. With UVC cleaning the air, these facilities can turn down their systems to lower speeds, run them for less time potentially, while still meeting higher indoor air goals. And the HVAC savings that can be realized with UVC are on a similar order of magnitude to the janitorial ones I went through. And they come with the bonus of much lower greenhouse gases. So all in all, a nursing home can save significant sums from the very first year while reducing the infectiousness of the air in the building and the surfaces in the building, creating a better building environment for residents, staff, and visitors. What's not to love about that? We also would encourage you all to check out zero.com/seniorcare, where you can find an ROI calculator to identify the savings potential in your space and reach out to us to discuss it in much more detail. So as we wrap up, I just want to share some of the hundreds of partner hospitals, schools, nursing homes that we protect every day. So on the healthcare side, you could see on here a few examples, including Stanford, Carle Health, Trilogy, which I mentioned earlier, and many others. On the education side, the Fort Bend Independent School District in suburban Houston. You can see South San Francisco, you can see Dallas, Norfolk Academy, and many, many other education partners that we work with and that we're very lucky to have as partners of ours. So with that, I will wrap it up, say thank you. This is my contact info if you have any questions. And of course, we'll take whatever questions you have on the line today right now. So let me turn over and have a look at what we might have in the queue. Okay. The first question I see is, one second. The first question I see is, how can continuous disinfection of spaces reduce costs for janitorial staff? So if you're continuously disinfecting, well, let's talk about this in two distinct ways. Let's talk about a classroom first, where you're continuously disinfecting the air, for example, with Beam. That can reduce the cost for janitorial staff, because if their current protocol says they have to wipe down the space every single day, or some other similar protocol, they may be able to reduce that There may be less of a need for that, and of course, less of a need for the products that they're using to do that work. And so that you can essentially, let's say, have them come every other day and reduce the frequency of the work that they do, and therefore reduce the amount of work that you need a janitorial staff to do. And we certainly have customers who've done that. On the surface side, in a bathroom, similarly, maybe you have a schedule of coming in and cleaning multiple times a day, and that may be less necessary, or at least part of the steps that are done may be less necessary for disinfection reasons. The second question that I see here is about how UVC disinfection contributes to meeting indoor air goals and reducing HVAC usage. So on the first point of indoor air goals, as I mentioned, and as Ben Boyer went into a lot more detail on last week, there are new standards that have been promulgated by ASHRAE, which is the Professional Association of HVAC Engineers, by the CDC, the Centers for Disease Control, and by Lancet, around the importance of increasing the air changes per hour in a room so that you reduce the microbial load of the air in the room. And generally speaking, there have been existing standards, ASHRAE standards at least, on the books, I think since the 1970s, for air changes per hour. And many of those have made their way into building codes over the intervening decades. And those standards were significantly lower. But the reality is that many schools, senior care facilities especially, tend not to even met the earlier standards, let alone the new higher standards. Additionally, these new higher standards in many cases really cannot be met by HVAC alone, especially in some spaces that have higher requirements, like a hospital waiting room. You know, a hospital waiting room in the new ASHRAE standards, I think, has a 40 air changes per hour requirement, which is really dramatic. That's more air changes than you see on an airplane, for example, which is one of the safest environments, ironically, for indoor air quality, and would lead to very uncomfortable space. Basically, you're sitting in a breeze at that level. So, in order to meet higher air changes per hour standards, you can either literally pump more air in, or you can clean the air that's in place, which is what leads to what we call EACH, or equivalent air changes per hour. And that's what disinfecting air in place allows you to do with a UVC product. So hopefully that answers that question. The second part of that question was about reducing HVAC usage, and that's kind of, you know, the other side of the coin, right? If you can do it with UVC, you don't have to do it with the HVAC system quite as much. And HVAC systems, by the way, are generally not designed around the principle of reducing microbial load. They're designed around thermal comfort. You know, what temperature is it? They're designed around ensuring that there's enough oxygen in the room. They're designed around ensuring that the humidity level is comfortable. Those are the kind of main drivers of HVAC design historically, much more so than disinfection. And so UV allows you to let the HVAC system do what it's good at, which is maintaining the right temperature and humidity, while letting the UVC disinfection take over the part that the HVAC is not good at, which is keeping the air clean. Now, there's a question here around life expectancy and system maintenance. So I will tell you that generally speaking, for our two products that we talked about today, we tend to sell them with a maintenance contract of 3 to 5 years. And over the course of that time, it's completely under warranty. Anything breaks, we take care of it, but generally there's very little maintenance that is required. Just if you think about Beam, it's basically an LED lamp. So just like other LED lamps that you might have in your home, you know that those things last for a great many hours. And I'm happy to follow up with you on exactly the specifics to answer that question, which I don't have in front of me, unfortunately, right now. Somebody else asked about the cost for the second year only subscription and maintenance fee. Yes, so in the kind of modeling that I went through today, that was the pricing model that I was using. So essentially, you buy the hardware in the first year, and then in subsequent years, you're buying continued access to our software platform. You're buying the warranty, you're buying support and service, etc. We have a couple of other models that allow you, for example, to prepay for 5 years all in. We also have a hardware as a service model that allows you to have a fixed price every single year. And in that case, actually, the first year cost is even lower than what I outlined. But for the sake of simplicity for this webinar, I just went with kind of the simplest approach, which is buy the hardware and then the service in the subsequent years. And as I said, in that case, you're going to make you're going to essentially pay for the hardware in the first year, and then because the price goes down in subsequent years and the benefits stay the same, you're going to make an even greater ROI in subsequent years. Now, the last question that I see here is about Vive and manual cleaning with or without using UVC. So, of course, Vive is not going to take out the trash, and Vive is not going to, remove any material that might be, let's say, on a toilet seat or something like that. But what Vive is going to do is going to make sure that that space is disinfected. One of the side benefits of that, actually, in a bathroom specifically, that we have seen is odor reduction, because what causes odor is typically bacteria. And so eliminating that bacteria eliminates the odor problem. But we can follow up with you with more information on your question. And then the last question that I see here, unless others come in, is about how data-driven hand hygiene policies contribute to reducing infection. So essentially, hand hygiene is the number one thing that anyone can do to reduce the risk of infection. We all heard that message loud and clear during the pandemic, and it is true. And we all also know from our personal lives that it is not that easy to wash your hands for 20 seconds throughout the day. And if you imagine a nurse or a doctor on rounds, every time you go into a room, every time you leave a room, every time you touch a patient, change a patient, take out a bedpan, etc., you should be doing that. And that's asking, a lot of people to do throughout the day, especially when they are, moving quickly, trying to get a lot done. And that's why it's very common to see that nurses and doctors and other folks don't have perfect compliance with what they should do. And so the point of a data-driven policy, or not really a data-driven policy, but the point of having data as part of your approach is that you can understand where and who is doing a good job and where and who is not. And our sensors, at least, are privacy preserving. So we don't actually know the individuals in any given case, but if you can imagine a number of hospital wards with sensors in every room next to the sink, for example, that know that somebody's, and next to the door. So somebody's entered the door and then not gone to the sink and then left the room. Well, we know that's an instance when somebody did not do what they should have done. Or conversely, somebody entered the room, went to the sink, spent 5 minutes with the patient, went back to the sink, and then left. In that case, we know they did do what they were supposed to do. And so when you add that up and you look across the entire hospital at a dashboard of that, you can see over time that, a particular ward is doing better than another. a particular shift is doing better than another. Maybe a set of rooms are not doing a great job, etc. And of course, you could also correlate that data directly to the incidence of infection. But even at a more general level, it's a known fact that kind of hand hygiene is going to improve outcomes, improve the safety of the space. So it can help you identify where you need the most remediation, maybe the most education, the most reminders, etc. Most of the studies that talk about the benefits of improving hand hygiene describe interventions that took place over a month or two or a year in a particular hospital in a trial. The challenge is making that a sustained effort. And in order to make that a sustained effort, you have to have data all the time. And the point of what I was describing is having a continuous way to measure and monitor, and therefore address the worst problem spots in a facility around hand hygiene. So hopefully that helps. It looks like that was the last question, so I will leave it there. But my email address is here. You can also reach out to us at r0.com. So if you have any other questions, we'd be happy to follow up. And I did promise a little bit more detail for a few of you, so I will follow up with you after the call. And very much appreciate your time today. I hope it was helpful, and we hope you'll join us for subsequent webinars from our series, as well as others that we do down the road. So thank you very much, and wishing you all a wonderful rest of your day. Bye.